it's very easy for somebody to go, okay, well, this guy's in pain and he's suffering, and let's get him on a prescription.
Sure.
And so they get him on the prescription, and then they end up, unfortunately, never coming off the prescription, never getting the procedure that they need. And I think we kind of take the opposite approach.
Yeah, I have a lot of patients who just say, I just don't want to take them. When we're talking about the spine and spine pain, I feel like we have so many more tools now that we can offer patients. With a spinal cord stimulator, like the name says, we're targeting your actual spinal cord. These can give people years of pain relief.
Hi, I'm David Segraves. I'm here today with Dr. Benjamin Sloop. Dr. Benjamin Sloop is a pain specialist. Welcome to the show, Dr. Sloop.
Thank you. Great to be here.
Today we're going to talk about chronic back pain and some solutions for people that are suffering from chronic back pain. So with that, tell me a little bit about what we can do for people that are hurting and have been in back pain for a very long time.
Sure. So, I mean, what a broad topic. I mean, massive. I mean, there's textbooks written on just chronic back pain alone.
Right.
So just like with anything, like you take your car to the mechanic, right? They got to diagnose the right problem first.
Yeah. And
then depending on that problem, they might make a recommendation on how to fix it. And certainly if they're changing the brakes, when the alternator is your problem, they're not going to fix your car, right? So really what you got to do is you got to determine the cause of the patient's low back pain first. That's not an easy thing. It can be very challenging, but we do a detailed history and physical exam. We'll take some imaging, ask some very specific questions about, does your pain radiate? Is it better with like what kind of activities make it better or worse? Things like that. And then we'll do some maneuvers, a physical exam to see maybe, and it's kind of a peculiar thing because we want to make your pain worse while we're doing it. And that's like, well, why are you doing that? And that's so that we can figure out what is triggering your pain, what kind of movements, because each one of those movements that might make it worse, that's giving us more information on what might be the cause.
So that's like a functional exam, basically.
Sure, absolutely.
Testing ranges of motion and this sort of thing, I'm assuming.
Yeah, and there's some specific tests that have been validated through scientific studies to say, yeah, if this test is positive, then it's most likely that they have this type of problem. Certainly checking reflexes and all those things can give us some valuable information there as well, but it's really about diagnosing the problem and getting the right source of the pain. There's like 30 different pain generators that can be the cause of your low back pain. So really it's dialing it in and figuring out what is the actual problem. And it's really an art. It takes talent and practice.
Oh, absolutely.
To do that. The way that I kind of divide this up, and everybody divides these things up a little bit differently, but we talk about anterior column pain versus posterior column pain. But anterior column would be like the discs.
Anterior's front.
Front part.
Posterior's back. Got it.
You got it. So the front part of your spine would be your discs, the vertebral bodies, okay, and all the structural elements there in the front. And then posterior column would be like the facet joints.
Now, let me ask you, how would you know if it's anterior or posterior causing the problem?
Sure. So a lot of times, and this is all pretty, I'm watering it down quite a bit, and it can be way more complicated than this. But typically anterior column pain is worse when you're bending forwards, and posterior column pain is worse when you're leaning backwards. And basically what you're doing is you're loading
that makes sense.
The front part of the spine when you're leaning forwards, and you're loading the back part of the spine. You're shifting the weight more to the posterior elements there. So that's one simple way to think about it. That helps you kind of dial in a little bit as to what I think might be causing your pain. Certainly there's a lot of patients who have anterior column pain and posterior column pain. There are patients where it's really not straightforward. And a lot of times on those patients where there's more than one problem, or it's not really as straightforward as we think, we might get more detailed imaging like an MRI to really show us more detail about what's going on, what the sources might be, where the biggest issues might be. And it's all related too. It's all part of your body, and they all work together. So if the anterior column is bad for long enough, well, the posterior column is going to get bad too, and vice versa.
It's sort of like a flat tire on a car. If one side's going bad, it's going to eventually.
Yeah, I mean, you got to rotate your tires, right?
That's right.
A lot of it's related and linked, and we see these patients who are in their 70s and 80s, and they have a little bit of everything. So sometimes it's not as easy as saying, oh, it's just your anterior column, let's
Yeah.
do this. Oh, it's just the posterior column, let's do this. So I like to start with simple, easy, basic things first. And so some of the simplest things that we do for like an anterior column pain or pain from the discs is called an epidural injection. And I think you've probably heard of that before.
Yeah, well, let me ask you about that. So specifically, and this is my understanding, so I just want to make sure that this is correct. So a patient that's suffering from radiating pain, for instance, pain that's going down their leg, or pain that's maybe shooting up their back,
Sure.
or a lot of times like sciatica,
Yeah.
is that something that we would use an epidural for?
Yeah, typically. So a lot of times radiating pain is caused from the disc, and the disc is in that anterior column. And most people have heard of like herniated discs or bulging discs. Well, those herniated discs, they put pressure and can irritate the nerves, and so that's why you get a radiating pain. Is it's irritating the nerve right that's in close proximity to it and causing the pain to go somewhere else. And a lot of times these patients come and say, my leg actually hurts more than my back does. It's more in my leg.
Yeah.
And so kind of back to the history and physical part, a key question, and I drill this into all of our providers, is it worse in their back or is it worse in their leg? And that's a key question to ask, because that's really going to change what we do to try to help them. An epidural is a great treatment for back pain that's radiating, especially like down into the legs, or if it's in your neck, it can go down your arm. And it's so common, and so many people have heard of epidural injections. Pregnant women get a version of this.
Is it the same as that sort of epidural?
Well, it's just so we could talk about anatomy for a minute if you want to. So the anatomy of your spine and your spinal cord is that in between the bone and the outermost layer of your spinal cord is the epidural space, and it's filled with like fatty tissue, and there's some blood vessels and lymphatics there. So it's just a space that's there that's in between the bones of the spine and your actual spinal cord. And it's not actually the spinal cord, it's the outermost covering of the spinal cord, which is called the dura. So we're epidural, we're outside of the dura. So we're outside of the actual substance of your spinal cord. And that epidural layer, that dural layer, is very thick, like leathery, rubbery kind of stuff. And so it could be punctured easily, don't get me wrong, but it's a thicker, durable type of material there in your spine that is really what protects your spinal cord, more than almost anything else there. So what we do for an epidural for women who are in labor is we actually put in a catheter in the epidural space. And we do this without an x-ray camera. Typically, we do it all just feeling on the patient's back.
Wow.
Because I have in the right area here. And it's you get a lot of tactile feedback from that as you're advancing that needle. You know when you're close. And when we get in the epidural space, we thread a catheter in, and that's just like a tube or a hose, if you will, really, really tiny. And when that's in the epidural space, we infuse local anesthetic medicines typically. And that's what makes women numb from, their belly down through their legs. And so that but they also kind of get weak as well. And that way it makes childbirth more tolerable, less painful for them. But when they have that in, they can't walk around because their legs are weak and numb. So we don't want to do that on our pain patients. Certainly it would help their pain, right? But you can't just sit hooked up to a catheter infusing local anesthetic medications for days on end. So what we do is we take a smaller needle. We actually use an x-ray camera. And instead of putting in a catheter, we just put in steroid medicines.
Okay.
And that steroid medicine will coat that disc and those nerves where they're irritated and get rid of the inflammation and help with that painful problem.
Now, I've had an epidural with you.
Yeah.
For my own disc issue. So I know what it's like, but for the average person out there who doesn't know what it's like, I think the concept of having a needle in your spine is a little scary.
Sure.
So tell me a little bit about, is it painful? If it is, what can be done for that kind of pain? And what the typical process is for doing an epidural.
Is the procedure itself painful? Mm-hmm. I think the epidural is probably one of the least painful procedures that I do. In all honesty, most people don't need any, kind of sedation or anything like that?
I don't think I got any when I did it.
No. Generally, I would say it takes 5 minutes or maybe less.
Yeah.
The process is this. We have you lay down on your belly in our procedure area. There's usually a couple of pillows underneath your belly that kind of helps straighten out your back and makes the posterior aspect a little more open, so it's easier to access. Certainly everything's sterile and all that stuff, but we use an x-ray camera to localize where we're going to access. We all have little openings in the back of our spine at each level, so we try to correspond that level with your pain. And certainly if you say, well, the pain kind of just goes down the outside of my leg or the back of my leg, well, we'd say like that's more like L5 or S1, versus if the pain kind of comes around the front and into my knee and then down into the inside of my shin area, we might think more L4. So we kind of target that based on where the pain's going, or maybe based off the level that's sourced on your MRI or your x-ray. And so we numb that level up using the x-ray camera. That numbing medicine, most people have felt that, feels like a bad bee sting. 10 seconds or so of stinging, burning pain, and then it's kind of done. Most people don't feel a whole lot else after that. Just numbing that skin is typically the worst part.
Wow.
We'll use the x-ray camera to advance the needle.
And so by x-ray, you're meaning the fluoroscopy?
Yeah, the fluoroscopy camera. So we can see, and we're not taking it live the whole time. We don't want to expose people to too much x-rays, but at key points, we're taking pictures to make sure that everything is going in the right direction. When the needle's in the right spot, we put in contrast medicines, and that's a unique kind of medicine that actually will light up on the x-ray camera that you can see the medication. So we put that in and confirm that, one, the medicine's going where we need it to go, and two, that it's not going somewhere dangerous, okay? And then we'll put in the steroid medications with that. Now, sometimes putting in the steroid medications, people say, well, I feel pressure in my buttock, I feel pressure kind of going down my leg. That's not terribly uncommon. It's usually not incredibly painful, and usually it goes away in a couple of minutes. We're putting medication already in an area that has too much pressure and it's kind of confined and irritated. So that's to be expected a little bit. And sometimes that clues you in that you are at the right spot as well. Okay, I'm putting this medicine in, it's irritating. Take out the needle, put on a Band-Aid, all done. Like I said, generally the needle's in your back for less than 5 minutes.
So it's quick.
It's quick.
Wow.
Really not any recovery. I mean, we send you home. I don't usually put you on any kind of restrictions. It's just do your basic stuff. Your back might be sore for a day or two, but it shouldn't be anything that's terrible for you. We get the flu shot and your arm's sore for a couple of days.
Makes sense. Well, let me ask you, so on the medication that you're using for epidurals, how quickly does that tend to work?
Sure. Yeah. So I read a recent study on this actually that said if you get relief by the 4th day or on the 4th day, you're likely to have a better outcome. Patients who get relief and it's later, like maybe the 6th or 7th day, their outcome typically isn't as good, or maybe it doesn't last quite as long. So generally within a week, you can expect to get about the maximum effect of the medication there. The typical duration, and this is pretty average for any steroid medicine, is about 3 months, or any steroid injection, we can tell you lasts about 3 months or so. So that's average, so we get some patients who get less, we get some who get more. I've had patients who have gotten a year off of a cervical epidural, same with lumbar epidurals. It just kind of depends on how bad the problem is. Typically tell people 3 months is the average. It's hard to know, especially on somebody that you're doing the first one on them. I have patients who come back and they say, and it's like clockwork. Yep, every 3 months, it's worn off in 3 months, and they're back, and they're back, and they're back. So everybody just responds a little differently to those as well.
Well, it brings up another question. So how many of these can an individual get? Let's say that they're suffering from, the radiating pain that's going down their leg. How many epidurals can they get before it becomes ineffective, or before we should advance to the next procedure?
Yeah, I mean, that's a great question too. And it's kind of one of those things where, like, I wish I had the crystal ball and I could predict the future and tell you. I guess the way that I approach this is, as long as it's working for you and you're getting 3 months or more out of it, keep going with that.
Yeah.
If it's not getting you, if it's getting you like a couple of weeks, then maybe we need to find something that's a little more effective for you. A lot of this, there's kind of gray areas. Certainly there's situations where it might be appropriate to give somebody an epidural injection every like 2 months.
Wow.
Like look, I got to have a back surgery, but I can't because of an insurance problem or whatever. And it's like, but the epidurals only last 2 months and I've got to make it a year. It's like, well, okay, this is a circumstance where I say maybe it's okay to be a little more aggressive with you. But I think in most circumstances, we want to say no more than 4 a year.
Makes sense.
Yeah. And there's been some also recent studies about bone demineralization and things with some of these injections. And I think and I think the old thought was you get too many of these and it makes your bones soft.
Yeah.
And I think that we're questioning that a bit more now. I think there's the evidence suggesting that it's not quite as robust. Certainly if you've had a bunch of compression fractures and we know you have severe osteoporosis and things, we probably need to stay away from them. But for most general individuals who don't have those kind of problems, it's okay to have every 3 months.
Makes sense.
Yeah.
Now, I remember in sports a lot of times, trainers and doctors, team doctors and things like that, they kind of only wanted to do injections on knees with steroids, I think for a maximum of like 3 times or it was something like that.
Yeah, and everybody has like their own kind of protocols and things. So it just kind of depends, but I've had patients who have done really good with steroids in their knees for years and years and years, and they just come back every 3-6 months and get their steroid in their knee and they're good to go. And some of that is patient preference too. Do you want to come back every 3 months and get an injection in your back? And not everybody wants that, right? So what I typically say is, one, if it's just really a huge burden for you to come in every couple of months and get an injection, or 2, they're just not as efficacious as they need to be, then maybe we need to look at something else. And where I would probably go with that, with an epidural helping you, is probably something like a stimulator for your pain, to be a more permanent long-term option. There are circumstances and instances where patients do great with epidurals for a couple of years and then they just seem to not work anymore. And I think what happens is we get rid of all the inflammation there and you're just left with maybe a mechanical problem and not so much an inflammatory problem, which can still be painful. And then again, I think at that point I would start thinking about a stimulator or something along those lines for most folks. The other thing that we do a lot for chronic back pain besides epidurals, and again, these are like quick kind of baseline procedures, is the medial branch block and the radiofrequency ablation.
Well, I was going to ask you about that. So on a medial branch block, which I definitely want you to explain what that is and why that is. But my understanding is if somebody's suffering from pain that is more focused on the spine or on the neck or whatever, that's when we're getting into an MBB RFA series?
Sure. So you're right. And that's one of those reasons we ask that differentiating question: is it more in your leg, or more in your back, or more in your neck, or more in your arm? We get arthritis in the little joints in the posterior aspect of our spine. They're called the facet joint. Very prone to getting arthritis, just like we get arthritis in our knees and shoulders and hands. So it's a very, very, very common source of back and neck and spine pain in general. And that's part of that posterior column. And the way that we test that is we do what's called facet loading. We have the patient, we put our hand on their low back and one hand on their shoulder. We kind of twist them and lean them back. And we call that loading the facet joint. And a lot of times the patient, oh gosh, like that really hurts. Ouch. That's what it feels like. And they'll even tell you, like, I can't lean back. I can't like reach up over my head. I can't, like, doing something where I'm like lean in a little bit of a reverse kind of movement is really painful and hard to do. That's a good sign that the pain is coming from those facet joints and that the medial branch block will help you. And so the way that we do this is we do 2 series of test injections first, where we put a needle in next and we actually put in some long-acting numbing medicine. And that numbing medicine, it really only lasts for like 4 to 8 hours, somewhere in there. And we do a test first. I tell people it's like a test drive. You're taking the car for the test drive. You're going to see if it meets your needs before you purchase the car, right? And your pain should be better pretty quickly, within probably 10 or 15 minutes. And it should be better for, 4 to 6 hours, 8 hours. Some people will tell it they got a couple of days. That's a bit uncommon, but people metabolize those medicines a little bit differently.
So let me ask, so if it only lasts for a few minutes or a few hours, this is just a diagnostic, or what's the point?
Correct. Yep. Diagnostic. So that's great that you get a little bit of pain relief, but we're just trying to make sure that we're doing the right thing. And we want to make sure that we have a high index of understanding that the more permanent procedure is going to be helpful for you as well. So we do those test shots twice. Yeah, it can be a lot for people, and I get that. It's what the insurance requires, so that's kind of what we have to do. If both of those test shots have helped you for 80% or so of your pain, we'll do what's called a radio frequency ablation. Now, and people may have heard of this as a rhizotomy or a nerve burn. A lot of people say, just kind of in the community. And so what we do is we use a small needle. We place the needle on the little nerve there. And basically this nerve, really, people say, well, you're going to burn a nerve. Am I going to be able to walk and things?
Right.
And yes, we're not going to burn a nerve that helps you walk. That would be, I would think, cruel, and insurance wouldn't let us do that, and I wouldn't want to do that to patients. So this little nerve that we're doing this radio frequency ablation to tells your brain that facet joint hurts, and it does a little bit of the innervation of the multifidus muscle there in your spine as well. So we use the x-ray camera, we put the needle down next to that nerve, then we test it. We're testing to make sure that we're next to that nerve and close enough that if we do the ablation that we are going to successfully ablate that nerve and prevent it from sending its signals. And then we do another test where we make sure that we're not close enough to any of the motor nerves to cause any sort of permanent nerve disability, anything like that. So there's safety built into doing that. Some patients want sedation for that. That's fine. I don't have an issue with that. If it helps them have the procedure, then that's okay. And I would say we're probably 50-50 on if the patients want sedation for that or not. But when that's done, the typical duration for that is 6 to 9 months, or 6 months to a year.
Wow. Significantly longer.
Significantly longer. I get patients coming back, and they're like 10, 11 months. They're like, I'm starting to feel this come back. It's coming back.
Because the nerve's going to grow back.
The nerve grows back.
I get it.
And they say, well, can we do it again? Absolutely, we'll go back in and do it again. When we do it the second time around, we don't have to do the test shots typically again, which is great. We don't have to go put you through all that again. If we know this is the cause of your pain, we know we were successful doing it before, let's just bring you back in and then burn the nerve and get you back to life and out of the doctor's office and doing the things that you want to do.
That makes sense. So you've done the MBBs series 2, which is at least 2, right?
Correct.
And you've done that to identify the specific nerve.
Correct.
And then we're going in and we're ablating that specific nerve.
Correct.
So once we've got the nerve that's causing the issue, they're getting relief for 6 to 9 months.
For the most part. Well,
Wow.
6 months to a year typically.
6 months to a year. Wow.
And again, it's one of those things where I've had patients get 1.5 to 2 years, couple of years.
Wow.
So it really just depends on the patient. But average is, I would say average for me is about that 10, 11 month mark. People are coming back and saying, I'm starting to feel this come back. Can we do this again? It lasts a long time. It's very durable. You can have it repeated. We asked about epidurals, like sometimes they lose their efficacy after a while. With this particular procedure, when your nerves grow back, they can grow back in little collaterals. It means it doesn't always grow back just as one solid nerve. Your nerve can grow back as like this little spider web network. And what that means is that it can be a little bit more difficult to ablate in the future because we're ablating a very small area, tiny. It's tiny.
Right.
And if that network of nerves is now spreading out over a larger surface, it's really hard to burn all of that and give good relief. But again, it's something that I take on a patient by patient basis. And if we've had success and success and success, and then all of a sudden we're not having success, we start thinking about maybe is there something else that can be done more long term to give me the same sort of relief? And the answer to that is yes. There's some great other options out there that can still be helpful for you in the same way, if not maybe not even better, if you've had success with the ablations in the past. But yeah, it's not an uncommon complaint that we hear.
Wow.
But this is the great.
That sounds like a great solution.
Yeah, this is the great thing about being an interventional pain doctor and having all these layers of options. This is just like the beginning. When people come in for their first visit, I mean, this is the bread and butter. This is the first thing that we're offering them typically. And there are patients who've already a lot of patients have already had this done, and they've not helped them, and now they're like, well, I don't want to take pain medicines. And, another pain doctor might not have another solution for them. And might say, well, now we're at the point where I typically put you on pain medicines. I used to do that in the past. I don't have a whole lot of other options for you. We'll start you on a little bit of pain medicines now.
Well, and sometimes that's got to be like an appropriate solution.
And it is. I'm not saying that it's not, but I feel like we have so many more tools now that we can offer patients that I don't have to say, well, it's about time for you to start on the Vicodin or whatever.
Well, and I think, the guys that have been on that, I feel like the guys that maybe aren't as trained as you on the interventional procedures and haven't done as many interventional procedures, it's very easy for somebody to go, okay, well, this guy's in pain and he's suffering, and let's get him on a prescription.
Sure.
And so they get him on the prescription, and then they end up, unfortunately, never coming off the prescription or never getting the procedure that they need. And I think we kind of take the opposite approach.
Yeah, I have a lot of patients who just say, I just don't want to take them. I'd rather hurt than take those.
Right.
And that's fine as well. And there are certainly patients who need them. I'm not really disputing that, but there are some peripheral nerve stimulators that we do where we can stimulate that medial branch nerve. We put a stimulator wire next to that medial branch nerve. That works great long term for people.
I definitely
we've
want
done
to
that
talk
very
about the
successfully. Yeah.
So peripheral nerve stimulator. I know we talked about spinal cord stimulator a little bit before. Peripheral nerve stimulators. What is it? What is its similarity to a spinal cord stimulator?
So very similar. Okay. I think your target is different.
Okay.
Okay. With a spinal cord stimulator, like the name says, we're targeting your actual spinal cord, versus a peripheral nerve stimulator, we're targeting a peripheral nerve. So outside of your central nervous system, outside of your spine. And so these are very versatile. When we're talking about the spine and spine pain, we're targeting a couple of areas. One, we're either targeting that medial branch nerve, and we basically place a stimulator wire right where we do the nerve burn, okay? And instead of burning that nerve to try to destroy it, we can stimulate it in a way that we relieve pain. Just like the spinal cord stimulators, you could do a trial first and see if it helps you. And the trials are about 7 days or so. There's another target. There's different targets there. One for low back pain specifically is cluneal nerve. That's the little nerve that comes over like the posterior part of your iliac crest or your hip in the back. And that's been very successful for targeting chronic low back pain as well. So there's a couple of different targets there, but it uses a little bit of electrical energy to stimulate those nerves, to change the way that they send their signals, to give you pain relief, and it's implantable. And we've found that these have been very durable as well. These can give people years of pain relief. One of the differences is that in the spinal cord stimulator, we implant like a permanent battery. With these peripheral nerve stimulators, because we're targeting somewhere in the periphery, and we use these for knees, for shoulders, for hands, feet. We can't put a big battery here in your arm or in your leg. There's just not tissue there to support it in most people. And so we have a little receiver basically that we implant, and the battery is worn externally over it. Certainly there's nothing that's going in and out of the skin besides the energy, but you would wear a very small battery. It's about the size of the new ones are about the size of an Oreo cookie over the little receiver that's implanted underneath the skin.
So it's like a magnet, is my understanding. Is it kind of magnetized over the...
No, it's not a magnet.
Not. Okay,
no,
well,
it's not a magnet.
That's my misunderstanding.
No, there's a little like plastic adhesive that sticks on your skin that will hold the battery where it needs to hold, and and so you would have to wear that like sticky externally over where the receiver is. But most people aren't dissatisfied with that. Most people that we found have been very, very happy with that.
So they don't have to wear it all the time.
Yeah, it depends on the patient. I think it depends on the target. We have patients who I think wear them all the time, and I think we have other patients who, we have one guy that I know with his shoulder who he'll use this for a day or two and then won't use it for like 3 or 4 days because he's still getting relief from the time that it was on. And so he's found out that he only has to wear it like 1 out of every 3 days or so to still get good relief.
Wow.
So it really depends. I wouldn't tell somebody, oh, you're only going to have to wear this like every other day or whatever. Typically, I think most patients are probably wearing it most of the time.
Makes sense. So guys that are suffering, so let's take somebody that's got knee pain that maybe isn't a candidate for a knee replacement.
Sure.
Would a peripheral nerve stimulator be a good solution?
That's a great option. Certainly, it's a minimally invasive option, so really incisions are small and very superficial. The only thing that goes in deeper in the structures there is the wire itself. So a great candidate for maybe somebody who needs a knee replacement, but the surgeon is like, look, your diabetes is too bad, or you're too overweight, or whatever reason, your heart's too bad, for me to do a full knee replacement on you. And there's a lot of people who just don't want to go through a prolonged 3 to 6 month recovery. So we do a trial. We put the wires in, 2 wires on the top of your knee. You wear it for a week and you can see how much it helps you.
Wow, that's great. So knees, shoulders.
Shoulders are very common, very, very, very common targets. Works great for those areas. Certainly anywhere there's a peripheral nerve in your body that we can like find easily on an ultrasound or on imaging is potentially a target.
And so you had mentioned, I know we were talking about low back pain, you had mentioned the cluneal nerve. Am I saying that right?
Cluneal nerve.
Okay, so that's also a potential for the PNS as well.
Correct.
Okay.
So that's great for somebody that's maybe had ablations and been successful, but now they're not working as well, or that effect's wearing off. A peripheral stimulator there at the medial branch. Talking more about back pain, there's another big target that we really haven't talked a whole lot, or big cause, that kind of fits into this kind of bread and butter basic injection type treatment place, is the SI joint. We see this very commonly. We see this commonly a lot in women. When we're having babies, the ligaments there in our pelvis become more lax and more loose so that the baby can exit the birth canal. And those ligaments don't always go back as strong as they should. And so that can create SI joint dysfunction. The other place that we see it a lot, or the other patient we see it a lot, is someone who's had a big back surgery in the past, or a lumbar fusion. What that does, it changes the dynamics of your back and how your back moves. And it places more pressure on those SI joints and more weight-bearing load on those SI joints than typically they have to bear. And what ends up happening is that joint deteriorates quicker and gets more arthritic and more dysfunction, and becomes a source of pain. And so, like most of these things that we talk about, we do an injection first to see if that helps you. The injection's typically very straightforward.
Yeah.
Small needle into the joint itself using the fluoroscopy camera, and then putting in a steroid medicine and seeing if it helps you or how much it helps you. People respond in one of a couple of ways. One, they don't get any relief at all, right? Okay, well, maybe it's not your SI joint. 2, they get relief and it lasts months. It's 3, 4, 5, 6 months, okay? Or maybe they get relief, but it's just not quite the relief that they were expecting, or for quite as long. So if you don't get relief, we need to look for another target.
Yep.
Or another source. If you're getting great relief, good. We'll bring you back in 6 months and do another SI joint injection for you. You're getting relief, but maybe it's just not lasting long enough. That would be a patient where I start to look at something like an SI joint fusion for them.
Okay, so let's talk about that, because I want to clear up. I've had a misconception about SI joints.
Okay.
And it could be because I've got a father, 3 uncles, and an aunt that were all chiropractors.
Sure. Yep.
And there is this concept that an SI joint is supposed to move. So I just want to talk about that.
Sure.
How much is an SI joint really supposed to move? And what's what's too much?
Sure. So I think every joint in your every joint in your body is supposed to move, right? If not, why is there a joint there?
Right.
Correct. So every joint in your body should move some. I think the problem with true SI joint dysfunction is it's moving too much, and it's moving to a point where, one, it's unstable, and two, it's causing you pain and discomfort.
So this is truly like joint laxity.
Correct.
So, and my understanding is, so if we're fixing that joint, if we're doing an SI joint fusion, which I definitely want you to go into what that is, if we're fusing that, then it's not moving so much anymore.
Correct. Or any at all. Okay, I think the question that maybe we need to be asking is, a joint's supposed to move. What happens to a joint if we cause it not to move? Okay, and I think that the SI joint, in theory, moves very, very, very little.
Yep.
And so I think the idea is that by fusing that joint, we're not creating much downstream effects, and that we're maybe helping the patient by helping them not have pain so that they can get out and exercise and do other things that are equally as important that they can't do right now. And so there's a little bit of a trade-off there maybe, but I think that that's why we evaluate a patient, and that's why we try to take them as a whole person and their life and the things that they value and are trying to do. And they say, Doc, I can't live with this pain anymore. I'm sedentary, I'm not playing golf, I'm not playing with my grandkids, I'm not happy because it hurts so much. I'm taking, bottles of ibuprofen and Tylenol every month, and it's hurting my kidneys and all these other things. Well, we need to fix that for you, right? So that has to be part of and nothing else has worked for you either, right? So you're miserable, you've tried all these other things and nothing else has helped you, and you're coming to me because nothing else has helped you and you're miserable, right? And so we need to try to do something to help you, not one, just to help your pain, and having stress because of pain is bad, but also improve your quality of life and your ability to sleep and travel and play golf and be active and do the other things that you want to do in life. And if that means that we take a little bit of movement out of that joint, that's probably a trade-off that most people are willing to make.
Well, I think so too, and I think there's a common misconception on, this isn't a knee joint. This is an SI joint.
Correct.
And an SI joint's really only got a couple millimeters of movement.
Yeah.
Like 2, maybe a little more, maybe a little less.
I think it depends on what you eat, but 3 or 4 I think is considered acceptable.
Yeah.
Anything more than that is considered dysfunction.
That's what I thought. Okay.
So you're taking something that moves that little and you're going to transfix that. I think most people argue that the downstream effects of that are very minimal.
Well, and so what I've seen is we get people that come into our clinic and they're like, well, I have low back pain. I've had low back pain for 30 years, this, that, and the other. They've been treated. Maybe they've had epidurals. Maybe they've had other treatments or whatever. No one has looked at the SI.
True.
So it seems to me like people can very commonly have an SI problem and misconstrue that as just low back pain.
Sure.
Does that seem right?
Yeah, very much so.
Yeah.
Very much so.
That's definitely what I've seen, and I think that this can be a potential solution. So this is covered by insurance.
Correct.
So tell me a little bit about the procedure and what's involved.
About the fusion. So for SI fusion, there's many different devices. There's many different schools of thought out there. There are devices that actually distract the joint, meaning like pull it apart a little bit, and also try to fuse it and hold it in place at the same time. There are others that transfix the joint or just like screw it together. I think most of the devices that I have seen are transfixing the joint. So what this equates to very simply is a couple of screws that go across that joint to hold it in place. Lateral approaches, there are posterior lateral approaches. What I've found to work is the posterior lateral approach. I think it is one of the safest and one of the simplest and one of the most efficacious ways to secure that joint and hold it together. The procedure itself, we do anesthesia for it. Small incision, maybe an inch or so, or maybe even less. Most of these procedures involve placing like a port or a channel down, and then through that we typically will drill out a small channel, and then we put a screw in through that. I would say it probably takes 20 or 30 minutes for one
that's
side.
pretty quick.
With this posterior, now these have been done for quite a while, and I think a lot of the older ones, the lateral approaches, these people are, they're having quite a bit of pain. They're using a walker or a wheelchair or some sort of assistance for a couple of weeks with walking and things like that. This posterior lateral and the approach, much less pain. People are walking the same day, quicker return to function and recovery. And so I think that there's also some misconceptions about the recovery and stuff just from some of the past procedure.
Sure.
Has been a little bit more involved versus now these more minimally invasive procedures. There's so much less tissue disruption, much quicker return to function, much less recovery time, much less limitations post-operatively. It's a much better option.
Makes sense. Well, things change. I mean,
Sure.
It's kind of like spinal cord stimulators. Your iPhone from when it first came out in, I think it was 2000 or 2004 or something like that.
Yeah.
Way different than the one today.
Totally different device.
So we've talked about epidurals. We've talked about MBB RFA. We've talked about SI fusion. We've talked a little bit about PNS. So while we're touching on it, what is DRG?
So DRG stands for dorsal root ganglion. And I think you're like DRG stimulation.
Mm-hmm.
So it's a type of stimulation that specifically targets a single nerve root, which is very interesting. The DRG is where a lot of the cell bodies live for those nerves, and it's kind of like this relay center between your peripheral nervous system and your central nervous system. So there's a lot going on there. It makes it a very valuable target for the type of patient that this is good for. Is someone who has really focal pain, and typically in a limb or an extremity. We can't do these cervical yet, so it's really just lower thoracic and down. So where we're typically seeing this is people, maybe you've had a hernia repair and you have nerve damage there from the hernia repair and you have hernia pain. That can be terrible pain. We find that the DRG works very well for that. Post joint replacement pain, so someone who's had a total hip or a total knee replacement and have complex regional pain syndrome type symptoms, which are things like swelling, redness, sensitivity, burning, a lot of these neuropathy type symptoms, but it would be in your knee or in your hip instead of in your foot where we're used to seeing it. They're great candidates for DRG. Also, people who've had surgery on their foot and have nerve type pain, but it's for focal issues. When patients are like, well, it's my whole legs, or it's more diabetic neuropathy where it's both legs and it's from my knees all the way down. You can cover that with DRG, but it's a little bit more difficult.
So it sounds like this is more where you've got a spinal cord stimulator is stimulating the whole spinal cord.
Correct.
DRG is more specific to a specific nerve or specific area.
Correct.
So it's less of a shotgun approach.
Correct. It's more like a sniper rifle.
Yeah, we've honed in, and we've got a specific nerve that we're trying to treat.
Correct. Or a very specific area that we're targeting. So the spinal cord stimulator, we put two leads up against that dura that we talked about in the spinal cord. This we put a lead or the wire for the stimulator goes out on the nerve root on that DRG, and you get to do a trial. It uses a very low amount of energy because we're so close to our target and our target is so focused.
So you do a trial on the DRG as well?
Correct.
Okay, that's great.
And I've found these to be tremendously successful. Stimulators, a lot of times people are saying something like, I'm 70, 80% better. The DRG, people are like, it's gone. It's 90% better. It's 100%. It's really incredible. And because it's such a focused therapy, we can really dial in and get pain really minimal. So we've seen a lot of success with these. We've done quite a few knees, and we see really good results with that.
That's great.
The other interesting application of that, and some of this is maybe a little more fringe or cutting edge, is that there are certain providers who are putting these at like T12, and they're getting good coverage of the low back. So there's a potential there. And most of these are people who've had back surgeries before. They have some sort of nerve damage in their spine or in the area of their low back because of their back surgery. And they found that this to be very helpful for that as well, which I think is very interesting and something I would be very interested in trying for a patient. Just haven't had that right patient come through yet to do that. But I think that the potential there for GRG is really quite phenomenal.
That's great. So while we're on that, let's talk a little bit about failed back surgery.
Yeah.
What can we do with somebody that went in and had a spinal procedure and is still in pain?
Sure.
Maybe the structure got fixed, but they're still suffering.
Sure. Well, I think it goes back to that original question that we talked about, is what's causing your pain. So did you have a big back surgery and you have scar tissue from that that's putting pressure somewhere? Is it mechanical pain? Do you have adjacent segment disease where the levels above and below the fusion or the surgery are deteriorating quicker now? So it really, is it your SI joint, because now all that weight is transferred down into your hips? So it really all goes back to that question, making the right diagnosis. A lot of times these patients we have to get an MRI on. I will say that we're having a lot of success with the stimulators in treating patients who have failed back surgical syndrome. And that's probably one of the most effective things, because it's so forgiving, and it covers such a wide area. We can cover your low back and your feet and legs. And most people who have failed back surgical syndrome, it's not just their back, it's their back and their legs. So it makes the spinal cord stimulation a very useful therapy for that type of problem. Sometimes people have loosened hardware and things like that, and they have to go back and see their ortho and have that repaired. So really, failed back is a really tough thing. The anatomy's distorted. Things aren't the way that you think they should be. There's scar tissue there that builds up that makes some of the other things a little more difficult. There's hardware in your way while you're trying to use your fluoroscopy camera to see the right thing. And so it just kind of complicates everything. But I always go back to those basic things and say, okay, is it something that we can treat with an epidural? Is it something that we can treat with a facet medial branch RFA? Is your SI joint? And pretty often those things are helpful in that type of scenario as well. There's always circumstances where it isn't, and then we're talking about something like a stimulator or an SI fusion or something along that more advanced kind of treatment path for our patients.
Dr. Sloop, I appreciate your time. Thank you for coming in today and answering some of these questions.
Thanks for having me.
If you guys out there are suffering from chronic back pain, please come and see us at Elite Pain Doctors. Or if you know of anybody that is suffering from chronic back pain right now, please share this with them so that they can get the help that they need.